Good morning, good afternoon, everyone, from wherever you are. This is the first of two webinars on the occasion of World Continence Week 2025, which kicks off today. We're very excited to share some of the innovative information that we have for you. And what I'd like to do is to keep what I have to say very short. We don't have a very long webinar, but we have a lot to share about the two patient decision aids which have been produced with the support of Medtronic via the company in the UK, that's Open Health, and Jasmine is going to open the session and explain to you what the patient decision aid is. She's the group director there and is the patient engagement lead, I believe, at Open Health. So you can see exactly who's who. I think most of you know who I am. I'm the president of WFIPP, and we are the driving force, if you like, behind World Continence Week. And each year it seems to get bigger and bigger, which is exactly where we want to be, to raise awareness of all forms of incontinence, so urinary and fecal incontinence. So enough from me. Dear Jasmina, can I leave it up to you to continue? Thank you.
Absolutely. Thank you so much, Lynn. Hello, everyone. It's an absolute pleasure to be here on the beginning of the webinar series for World Continence Week 2025. As Lynn said, I will be leading this webinar as a means of introduction. I'm a group director of content and storytelling in the dedicated patient engagement practice at Open Health, a global communications agency. It has been our honor to be trusted by multiple stakeholders, including Medtronic, in the creation and production of these, in the support of the co-creation and production of these wonderful PDAs that we're about to present to you today. We're also delighted to be joined by Dr. Pedro Blasco Fernandez. Dr. Pedro, if you'd like to give an introduction, over to you, and then I'll talk us through the next stage.
Hello, Jasmine, thank you for your kind introduction. It's a pleasure to be here, and I think this is a very, with the years, we have been seeing different changes in the Continence Week. Now we are a step forward, talking about including patients in the decision of their own treatment. I think this is a great step forward, and it is a pleasure for me to be here. Thank you, Lynn, for including me here as well. We can go ahead whenever you want.
Thank you, Dr. Pedro. So just a little overview of our talk today. So we've obviously done our welcome and introductions. I will talk you through a little bit about the theory behind the methodology we followed in supporting the creation of these PDAs. These include our deeper understanding from a health, psychology, and behavioral science perspective of shared decision making, but also in drawing on experience from other therapy areas on the value of fostering a collaborative environment for co-creation and validation of any materials used by a community in any kind of therapeutic area. Then we'll have the pleasure of presenting the two PDAs to you. As Lynn said, these are both across the therapy areas of overactive bladder, but also fecal incontinence. And then we'll open the floor to questions. So without further ado, a little bit about the key value behind these two documents. So as Dr. Pedro said, things are changing in terms of attitudes and how people engage in their treatment decisions. By definition, from the National Institute for Health and Care Excellence in the UK, shared decision-making is a joint process in which healthcare professionals work together with a person to reach a decision about their care. And that term together is very key, but also it implies not only an action, but also an element of preparation and an element of education, not only in terms of behavior, but also from a scientific, medical, clinical, and beyond the clinic point of view. We know a lot about shared decision-making from other therapy areas, but one thing we all have in common is often in treatment decisions, both parties can feel that they aren't communicating. Healthcare professionals can feel that their message isn't getting across. Perhaps they don't, in a time challenging or other practical challenge perspective, perhaps they don't have the tools they need to be able to get complicated messages across quickly, or perhaps they already sense that there's a part of the picture that they're not seeing. Patients often report feeling invisible or feeling unheard, or perhaps being unable to really get across the key issues to them. They often come away with not only frustrations, but also in worst case scenarios, treatment regret, which is what we're trying to avoid here. So what is the solution to this challenge that we all feel, both from all stakeholder perspectives? Firstly, we know that research has identified the key factors that affect any person's readiness to make a decision, and that also affect the quality of that decision. Because, you may be a very decisive person that goes into a clinic conversation and feels very confident in communicating what you need and getting what you want. But in hindsight, you may think, was the quality of that decision the right one? Did I actually take the right time? Was I as prepared as I thought I would? So what factors affect this? Obviously, time is the golden word across all audiences. Patients need more time. Healthcare professionals have increasingly less time. So, but it's not just the concept of time in terms of duration, it's also in terms of quality, and actually in the terms of cascade. So appropriate timing of decision support for an intervention means that those timings also need to be in the right order and with the right requisite knowledge gained before, and with enough time to ensure that you can challenge that decision a little bit later. The type of decision that you are facing and where you are in the clinical pathway also affects how ready you are to respond, but also a general understanding of the treatment and management options available. Now, this is key because it's the very foundation on which these two PDAs have been built on. Understanding both the benefits and risks of each treatment and all the management that goes in a wraparound way into your care, but also in the clinic and beyond the clinic, is also incredibly important. How you feel, how supportive you feel in that deliberation process and the decision that you choose to make is also essential. And as we allocated before, having enough time to consider all of the above, weigh out those available options, communicate any questions is key. So a key theme that comes out of this is very much an unmet need of education. It isn't just a practical piece. It is the fact that there is actually quite a lot of information that a patient doesn't need to just be aware of, but they need to be very comfortable with. They need to have comprehended it and to be able to see how that will, in literal terms, affect their everyday life as well as their condition. What is the benefit of conveying that education and going that extra step? And that is understanding that shared decision-making, being able to have those tools you need to actively participate in shared decision-making, can lead to improvements in many things. First of all, people can feel more satisfied with care. They will immediately be more involved. They'll have improved communication. They'll have confidence in their own knowledge and self-care skills. And self-care is a very key issue across the board of therapy areas. They'll obviously have improved knowledge about condition and treatment options, which will benefit them in the long term. And there'll be significant behavioral outcomes that also include adherence to medication, adherence to a treatment plan, and behavior change, we hope, in an overall quality of life. So how can we build these solutions that embody the spirit of shared decision-making in a meaningful way that can be adopted by the community? One of our key takeaways from these projects was that it is incredibly important to foster an environment for collaboration. So not only are you hoping that through shared decision-making, patients and their HCPs collaborate together, but these solutions that they're using should also embody that spirit. And in the examples that you're about to see, and I'll hand over shortly to Dr. Pedro to talk you through the first one, we were very proud to utilize the concept of a dedicated steering committee for each of the 2 therapy areas, with representatives across all the specialties that are involved in these specific pelvic health treatment pathways, to ensure that the information that goes in them is informed by the experts that are part of those conversations, that include patient and patient advocacy input, so that both perspectives are considered, and that therefore will deliver not only a trusted level of quality of treatment education, but true value of the lived, that will benefit the lived experience for patients and HCPs. So without further ado, Dr. Pedro, over to you to talk about our overactive bladder PDA.
Thank you very much, Jasmine. Adherence. Adherence to overactive bladder. I'm not going to talk about what overactive bladder is, but we have been working in adherence for, I'm very worried about adherence in overactive bladder for years now. For more than 6-7 years working, looking for improving adherence to treatment for our patients with overactive bladder. Beginning from what we are getting now, this PDA, it doesn't come from nothing. It comes from a lot of steps we performed before, clinicians and patients looking to get the best treatment and the best option of treatment for this condition. When this is only a point. For years, we had anticholinergics treatment for overactive bladder. They had a problem of dry mouth and constipation as very, very useful. Very often the patient had this problem. So when a new kind of treatment was beta-3 agonist was appeared with no dry mouth, we all thought that this was the solution of our problems. As you see in this graphic here, in this paper of Chappell, sadly, the adherence of the treatment is a little bit higher with mirabegron, probably because it has not the adverse events of dry mouth, that is the most usually seen adverse event. But if you see, the curve is very similar to those we saw with anticholinergics. So that made us think that the problem was not only the treatment, but the treatment we give to the patient and the way we work with the patient. That Jasmine said at the beginning, very well said from my point of view. For a lot of time, the patients with overactive bladder are almost transparent. So we needed to make them visible to practitioners, to clinicians, and we needed to work together, because for sure we discovered from 1917 we have been working in this issue, that working together, patients and clinicians, gave us the best way to get the best adherence. So you need time, you need information, and you need listening to patients. So what the first thing you need is giving an appropriate information, a very fit information. If the patients go to Google, or they go to internet, they will come back with probably not the information they need. So I think working with WFPP and other scientific societies, we discovered that being present in the information, the benefit, and elaborating benefit information for patients was a very important issue in order to improve adherence to our treatments. So some different stakeholders of clinicians and patients interested in developing a tool to inform our patients work together in order to work with these two objectives you see here. We need to deliver accessible educational material to support shared decision-making, because shared decision-making is the only way of working to improve adherence. This is not a matter, this is a not life-threatening condition. So we need to work together with the patients in order to know where do we want to go together? So 3 points very important when you are trying to elaborate benefit information. In this tool, we asked ourselves if really with this tool could reach the need of the community. We asked ourselves if there was this necessity drill in between the patients with overactive bladder and their families. We were very worried about elaborating an accessible content to lay the audience. And the most important thing, all the information should be very plain but accurate and transparent. We need to be very fit. We need to elaborate information, very fit information for our patients in order to get to make them know that what they are reading, what they are listening, or what they are getting the information is a very fit area and they can be very confident because there are a lot of committed professionals behind that. So we needed to work together, clinicians and patients. This is the first page. You can see of the tool. It is an interactive PDF. If we go to the practical issues, you will find there a lot of information and of different options, different line of treatment, and how to get to them, and which do you think the patient think they could be better for them. One important thing of this tool is that make patients think about their own condition. We have been using that with a little amount of patients in our hospital. And for example, they asked us to include in next versions frequent asked questions in order to give clues to the patient in order to should you be worried about, what should you ask to your doctor in the next visit to the office, because sometimes the patients are not they're not very sure of what they are suffering from and what do they need to ask about, and even they don't know which could be the problem in the future. So we go to the next slide, please. We elaborated the tool, and the tool should be accessible, so you can find them for the moment at WFPP support Incontinence website and CNUC website in order to access to it, to have the information that you need to receive treatment for overactive bladder. It's very important when you are navigating through internet that you go to very confident places in order to get very fit information. This is a must for clinicians and should be a must for patients associations. So at the end of the day, we are working there. Please go to the next slide. We are working here together. We are getting more people involved with the time. EAU have endorsed this tool, APNUC, Portuguese Association of Urology, as well as APDPA, this Portuguese Patient Association in Asia. This is a Spanish Patient Association. So we are more with the time, and we will be more with more time, because that means this is necessary. We need to work in this way, and this is as important of using the good treatment for our patients. This is not a matter of cure, because sometimes we cannot cure the condition. This is a matter of care. And when we are getting to this point, we are facing a very big change. This change began for us in CNUC 8 years ago, in 1917, when we discovered somebody. We had a plenary session in our meeting. It was called Somebody is Not Doing Their Homework, because we discovered, or we thought seriously, that thinking only in your treatment options or line of treatment was not the only way of improving adherence. From them, in 2017 in Canary Islands to this year, it has been a long journey. We have met we have met a lot of people here, as Lynn, WFPP, EAU. I wouldn't like to miss anybody, but a lot of people we have been aligned, and we are for sure getting in facing a really important change that won't be only in the clinical aspects, but in the way of managing our healthcare services. Thank you, Jasmine, thank you, Lynn, for your confidence in me to talk about the PDA. I think this is one step forward, very important, as I said at the beginning, in our journey to the right way of treating of patients with overactive bladder. Thank you very much.
No, thank you so much, Dr. Pedro. Thank you for that presentation. What I'll do is I will introduce the second PDA because it's very much linked with the successful reception of the first one that was created in overactive bladder. And then if we have time in this webinar, we'll do a quick walkthrough so that everyone who hasn't seen these can see the content that is involved in these. Now, each of these PDAs was developed, as we said, with the support of a steering committee and guidance from that steering committee on what the appropriate content and focus needed to be to make it relevant to the lived experience of patients. We learned a lot in the process of the creation of the first one. We understood that basically the strong visual identity that we created bespoke for the OAB PDA was important because it was user-friendly and easy for patients. I'm just going to pause while I mute one of our Mary Lynn, we have a bit of background noise. If we could just ask participants to mute, would that be okay? I can't seem to mute.
Just mute everyone. Can whoever's online, can you please mute yourself? Adriano?
Apologies, just
Okay.
if I could just do it without but yeah, it didn't let me.
Yeah.
Okay, I will carry on, and I'll just have to talk a little bit faster. So a little bit back to what we learned worked really well. So in the first PDA, we learned that a strong, clean user experience was key, that scientifically rigorous information, but delivered for a lay audience, so in an accessible format, both in terms of language, but also in presentation, with bite-sized small chunks of information, worked really well, and people responded to it very well. And again, that original methodology of the content being based on that deep research into the unmet needs and the experiences of those with incontinence and the implications on their life outside the clinic. So things like their behavior, their ability to communicate, and their general well-being were key. So these were key items that we knew needed to be maintained. But there were other areas that we thought we could also evolve, because everything is obviously a learning experience. So we wanted to approach the topic of fecal incontinence with additional compassion. Our insights showed that there was a higher emotional toll, or emotional toll was just more of a focus. We knew that we needed to provide deeper information about the full spectrum of treatment options available, including lifestyle interactions and choices and medicines. This was something that was emphasized to us by the HCPs in our steering committee, and how we needed to definitely go a little bit deeper beyond the top line education or a standard form of education, and that guidance for practical day-to-day life was key in this particular population. So again, lots of ways in the way that we not only replicated the wonderful work of the OAB PDA, but lifted it up and learning more and offering more to patients as a result. We're absolutely proud to show you now that this is the new patient decision aid for fecal incontinence, as we said, based on the original one for OAB, but specific to fecal incontinence. It has its own look and feel, as you can see, that is aligned with the previous one. And it launches today. Today is the first viewing of it to celebrate World Incontinence Week. So what I'll do next is I'll show you where these are available, and then I may stop sharing so that I can click on a new screen to give you a little bit of a tour. So as you'll see, both of these are available on sick.org. They're live at the moment. You can both download them and click on them to explore them on the web. Before I click and give you a tour, I'll talk a little bit about where we are in the journey for the fecal incontinence, because as Dr. Pedro said, we've had the opportunity to have a lot of feedback on the OAB PDA, but because we've just launched, this is quite new. So just to give you an idea, we kicked off the project in October. We brought together the steering committee by the end of the year. We did a full deep data immersion, including interviews and steering committee meetings. We had our co-creation workshop in the beginning of the year, the first quarter, and created a draft of the content. It was validated by May, and then today is the first day you'll see the final first design draft that's live on the audience. So we've only had this first milestone today, but we're hoping that there are many more to come, including an awareness campaign and additional endorsements for this PDA. So bear with me while I stop sharing just for a moment. And I will move you to my other screen. So 1 second. If Dr. Pedro doesn't mind, I'm going to show the Overactive bladder decision aid as well. Wonderful. Okay, here we go. And here we are. So what you'll see here is the live bladder, Overactive bladder PDA that is live on the WFIPP website. Literally, this is what you see when you click on the landing page, and then you have the option to open this as a PDF. So when we do that, it opens in a separate page. And obviously, if you download it, you get all of the features, because as Dr. Pedro said, it is interactive, so it means that you can click through. But what I thought might be a good use of the next few minutes is to give you an idea of what is in those first bits of content, and then everyone can go separately in and have a look at the content in a deeper way. So firstly, the importance of that co-creation, that collaboration, but also the trusted source of information. Something as a group we feel really strongly with is that valid, trustworthy information should be the first thing you find when you search as a patient for information about a treatment or a disease or a therapy area that you are interested in or that affects you. And we felt it was very important to ensure that you have full information about the people behind this tool and their affiliations. And you can find all of that in the steering committee upfront pages. And as you can see it here, it is very robust and represents multiple geographies. We then move into our contents page. So again, this creative demonstrates all of the different phases when one is going through that treatment experience with OAB. So first, an upfront section on what is overactive bladder. Often you get a diagnosis, but you're not entirely sure the deeper sort of information about it, any scientific facts, any elements of biology that maybe you didn't know. There should be no shame when learning about a condition and filling in educational gaps you have. Not all of us are trained doctors when we go to the clinic, but we're all human with bodies that we need to learn a little bit more about sometimes. So this section covers how it feels to live with OAB, what causes OAB, and who is in the OAB healthcare team. Another area of confusion often is the clinical structure, and especially when a multidisciplinary team is involved in care. Understanding how those people are different and how they have different remits and how they have different reach and different roles in the treatment decision-making process is absolutely key, because that way, as a patient, you know that the conversation you are having is relevant, or it needs to wait, or needs the buy-in from another person, etc. We wanted to make sure that the OAB PDA gets straight to the point pretty quickly for OAB, and that is understanding your treatment options. And as you'll see here, we have a table summary of the 3 main treatment options for the management. We then put them in a little bit more detail, as well as the additional options and why monitoring is hugely important. This is a very meaty section. As you can see, it covers 7 pages, because that is obviously the whole point of this booklet. And then the second most important point, which is how do you choose what is right for you? These sections involve a lot of practical guides and how to talk to your healthcare team about your treatment options, common barriers to personal empowerment, talking to your family and friends about your OAB treatment options, and identifying additional support needs. Common barriers is a very important section because, again, people learn from each other, and knowing that something that you found hard was also found to be difficult by somebody else often gives you that freedom to lose that inhibition to address a problem that at first seems very challenging and difficult to support. Finding further support. So we have here a mythbuster. A lot of the time we've found, and our data immersion has also shown, that people come to treatment decisions about difficult conditions such as OAB or fecal incontinence with preconceived ideas that they may have formed across the duration of their lives from various experiences or relatives or people they've known. It is important to clarify myths up front so that there is no fear and that there is full transparency as to what lies ahead, what might lie ahead, what could be your life, and how you might be affected. Top tips to manage your OAB symptoms, and then helpful organizations based in the UK. This particular PDA is the UK version, but the translations of these PDAs have had this section adapted to make sure that it reflects that local region, so that all regions where the language is available have that localized information and you're able to find support nearer to you. Our appendix also covers the project in more detail, including a further deeper dive for those that are interested in what is shared decision making, what are the main principles, what are the benefits, and also what if I don't want to participate in shared decision making? What if I am more of a traditionalist in my approach and really just need to have my clinician's view as to what's best for me? As I said, shame and empowerment and transparency are key principles behind the creations of this group, and we want to know that patients' views are included whichever way whichever direction they come from. So I won't click through the whole thing because I want to also show you the fecal incontinence one, but I'll just do a quick demonstration of the type of content you can expect to see. The very clean, patient-friendly design, and as you can see, the copy, it's really important that it's all been chopped up into small digestible bits and has gone through a health literacy and accessibility checks from the Open Health team. So again, I will stop sharing there and flick over to the PDA for FI. If you just bear with me one moment. Okay, here we are. So we have here, again, the link to support incontinence.org. If we click on the FI patient decision aid, it takes us to the dedicated page, opens in a separate page. Again, as we said before.
Sorry, we don't see your slides.
You don't see it? Oh, apologies. No. It would have helped if I had clicked share.
Yeah,
There you go. Apologies. So as you see, we were in the supportincontinence.org page. You click, it opens in a separate page. You can also download it so you get the full interactivity. And this is how it's visualized on a web link format. You have a similar clean design, slightly different concept so that you can see the difference between the two therapy areas, although they both still fall under the pelvic health. And then all of these buttons, as with the other guide, are interactive and help you, and you have the same sort of navigation. So navigation front and back, and beyond. What you also have here is the full declaration pages, the full transparency of the steering committee and affiliations, an introduction on the partnership and how it was created. And finally, what you can see, what will benefit you from this guide. As we said, an emotional support and empathy was a deeper emphasis. So some of the writing has been tweaked slightly to address that audience. There's a bit of a user guide here into what you can get from each section before you get onto the contents pages, purely because there was quite a lot more detail in the chapter headings. The chapter headings, very similar format and structure, and just slightly different weighting inside each chapter. But about FI, what is FI, Mythbusters, what causes it, living with FI, and your healthcare team. We had found that the Mythbuster and OAB performed really well, so we've moved. It was recommended that this section was moved up earlier into the document because it was really valuable to patients. Understanding your treatment options, and you'll see how here the weighting is different purely because of the needs of the condition. So there's not just a clinical treatment focus, there's also a lifestyle treatment focus, interventions that you can do at home, interventions that may not seem quite as effective to a patient that's new to the condition, but that in the long term can have a huge benefit to them. Choosing a treatment section, again, how do you decide what a good treatment plan is for you? How do you talk to your healthcare team? Key questions to ask. This is an important section because often, we didn't pull it out in the previous one, but it also exists for OAB. Often verbalizing questions is the biggest challenge. So support with prompts, with how to clarify what you mean is hugely valued by patients, and this gives you that. Knowing when to try something new is another interesting chapter in this particular document. Again, not knowing when to voice that you're concerned about things not moving or not sort of improving. Really important how to know how to communicate that effectively with your healthcare professionals so that they're also aware. The support sections are very much similar to the OAB PDA, and finally the appendix as well on the theory. I'll click through a little bit just so that you can see the slight difference in design, but above all, and a nice one to land on, it's really important to understand all the misconceptions about your condition and to really address anything that you already believe that might not be true so that you can move forward to something that will genuinely help you. So yes, with that, I will stop sharing and take us to questions, if that is okay.
I think I'll come in with a question, if I may. Thank you so much. It's good to see the interactive version of the FI. We know this is absolutely brand new, and so great that we can start World Continence Week with the PDAs. I have a question, which is, now that we've got these wonderful how should I say, tools. As Dr. Pedro was saying, they started several years ago already with this idea of shared decision making, and this forms part of shared decision making. If I ask Dr. Pedro, first of all, how do you think we together, as the various stakeholder groups and steering committee, can make sure that the OAB PDAs and the FI PDAs are spread everywhere that they need to be? Because we all think this is wonderful. We've all been working on these tools. So of course we think they're great, but we need to do more than that. We need to get out there and make sure that the dissemination works. Have you any ideas on that? You're on mute.
Yes, thank you, Lynn. I completely agree with you. This is not only a matter of dissemination, but this is a matter of using these tools as clinical tools.
Yes.
So I think if we believe this is useful for patients, we need to. I think the first thing we need to do is to test if we are right, because we think or we can be convinced about one situation, and after that it's not as useful as we consult, because our colleagues give a lot of good information. So point one is very important as a dissemination tool. So I think we need to giving access from WFPP, SINU, EAU, AAU, APNUC, all the societies and ASEA and Patients Association as much as possible. And we are now we are designing in our center a study in order to test how useful are these tools with patients. I asked to 5 patients. I can remind they are good patients, good friends now, because I have been treating them for years, and they gave me what they thought about the PDAs. So all of them, they were very happy, but they gave me some ideas to improve in other editions. But the most important thing is using that as interactive PDF, as basically as the same way we use more or less the informed consent. So this will be from my point of view, this will be the way of spreading in each country, each area, and each hospital the tool for our patients.
Thank you. I think so. I think that now that we've actually got the tools and that we've explained what the intention is of the tools, it is how to best make use of those tools to the benefit both of the patients, their families, and the healthcare professionals. And I'm going to ask exactly the same question to you, Jasmine, as from your professional design point of view and all the work that we've all been doing together. Have you any suggestions or ideas?
I do, and that is to continue the formulated plan, which is making it accessible to audiences that are difficult to reach. Often
Yes.
language is a key barrier. There is a lot of information. Admittedly, you have to do a lot of work to find it, and you have to draw your own conclusions. And sometimes, but in English, you have more choices. So already, with the OAB PDA, the project team behind that has supported 11 full translations. And I would suggest that they grow on those translations, and they obviously replicate the same in FI, because language is a barrier, especially in the age populations and demographics of the patients that are affected by these therapy areas. I think going on with a communications campaign, I know there is one beautiful campaign underway that will hugely support the uptake of these on a social level. And again, just spreading the word. If you have good experiences as a patient or an HCP, don't hesitate to give a good review. Often good clinical tools are very similar to any other experience that you might have in your life. More people need to know about it, and they can do that by you using the algorithm to support that as well. It is not a bad thing to go out and put on your social pages or to write to WeFip or to write to your HCP that something has been useful, because they can use those insights to make sure that those products evolve and are available to more people.
Yes, quite definitely. And I think we're making quite a lot of progress. What transpired last week, there is now an MEP interest group that's been set up in Brussels with 12 MEPs so far on continence health. So this is from the political point of view. I think we need to engage those politicians and step up the mark, so to speak, and make sure that we involve not only the healthcare sector itself and the various clinicians or physical therapists and hospitals and so on, but go that extra mile. I think we need a brand new campaign. So we don't just need World Continence Week, we need a campaign to promote the two PDAs. And I think, as Dr. Pedro said, the way to do that is also via the scientific societies, and there are many of them. So we've got a lot of work cut out, I think.
Think, Lynn, to add to that, I know
Yeah.
there is a lot of great work in the campaign underway, so hopefully you'll be seeing a lot more of that. But absolutely, when people come across it, please share it. Please like it. Please comment underneath if you found it helpful. As a community, if we promote these tools when they're good and when we value them, that just helps support continuing that work and allocating the resources that are needed to those types of projects as well. So yeah.
Dr. Pedro, would you like to add
Yes,
anything to that? I
yes,
think
Holly.
you do. Yes.
This has been a long journey, as said. We and Lee, you know, we have been discovering new frontiers. We have been discovering new people. We have been discovering new way of doing things. Here is for sure a very powerful tools. These two PDAs are really very powerful tools, very well designed tools, and listening to people, patients and clinicians in the societies, listening to clinical to doctors in hospitals and patients. For sure, we will improve them and we will disseminate them for the success of overactive bladder and fecal incontinence treatment. I'm pretty sure, and we are in some way we are discovering things at the same time we are doing our way. Lynn, you know.
I think I feel very much that we're pioneers all together, this steering committee, in having produced these, and they look brilliant, the paper versions too, which we had at the recent European Association of Urology Congress in Madrid. And of course, we gave out as many as we could. But I think that it would be great to have these in every hospital, every sort of waiting room, and you know, just the normal ways of getting journalists involved, getting the media involved, and not just within the European scene. We're going far further than that. I think certainly as a global platform, we're talking about other continents as well. And there's been so much invested in every sense, energy, work-wise, finance-wise, that we really need to go further. And I think, Jasmine, you've got something which I'm not aware of as yet, but I'm sure you're going to enlighten us and tell us what the next stage will be now that we've got the tools.
Absolutely, absolutely. As I said, there is an awareness campaign underway. I think it also launches this week, but I don't want to spoil the surprise. I know we've got Florian online, who is very heavily involved with that project, and the exact launch dates. But again, the point of that is, again, to raise that awareness of these wonderful tools, to make people with OAB and FI understand that they are heard, that they have somewhere to go. It is all of this work all boils back down to the patient, finding a way to really make them feel heard and foster an environment where they can be understood and have their needs met in a collaborative way. So yes, some wonderful translations ongoing. As anybody knows, making translations true to a region and true to the demographic within that region requires an additional level of skill. We're incredibly proud of the work that's gone into those for the OAB and look forward to doing them NFI as well. And then again, raising that awareness so that eventually that can reach those bigger ears that you mentioned, Lynn. You know, it is all about having a policy in place, and what Pedro said earlier, having that change mindset. So this is just how you will operate from now on, not this is how to learn how to embrace change. You know, maybe one day we won't have to explain the concept of shared decision making. Maybe one day you'll have people walking into a clinic and going, I know exactly what to expect, and I know that I can voice my concerns comfortably, and I know what language to use and where to find my information. So yeah, we've done the very key first steps. There's some excellent sort of next evaluations of this, evolutions of these projects ongoing, and hopefully there'll be another webinar where we can tell you more this time next week.
That sounds absolutely great. And I would say to our audience here, and I know there'll be a lot more on demand later on because we have the registrations. I would also say, please do your bit as well. So now that we have these tools, it's essential that we use these tools for the purpose for which they were prepared. And with that, I would say thank you so much, both to Dr. Pedro for his insights and to you, Jasmine, for walking us through what the months that we've had walking through and commenting and doing, and now we have the finished products, which are brilliant. So thank you very much, everybody, for this first webinar, and I wish everyone a very successful World Continence Week. Thank you.
Thank you.
Thank you very much.
Thanks, Pedro.
Thank you, Lynn. Thank you, Jasmine. A pleasure.
Thank you so much. A pleasure for me too. Thank you.
Oh, someone liked it. Jenna liked it from Medtronic. Yeah. You want me to stay online, Jasmine, you said. I can't hear you.
I will stop the recording now, right?
Thank you. Yeah, that would be okay. Thank you. I think we still have some people